Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Karen Simone and Michael Yu on 2C drugs and novel psychoactive substances in Northern New England. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes again. First, neither of the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speakers in this webinar are their own and do not represent the positions of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold all questions until that time, or you can place them in the chat feature in Zoom. Slides and materials from today's webinar will be sent out in the follow-up email along with the survey link. And now I'd like to give Michael and Karen an opportunity to introduce themselves.
Hi there. My name is Michael Yu. I'm one of the pharmacists and poison specialists at the Northern New England Poison Center.
Good morning, or I guess almost good afternoon. I'm Karen Simone. I am the director of the Northern New England Poison Center serving Maine, New Hampshire, and Vermont. I'm a clinical toxicologist. I've been working with Dr. Yu for quite a while now, and Mike is known well at the Poison Center for being the one who is always in the middle of anything that's new, interesting, and different. He has a very unique way of looking at things, and I think he'll do a very nice job of explaining to you everything you'll want to know about these new types of drugs. And before he gets started, I just want to point out that in poison control, people are always asking us what's new and what's different. And to be honest, everything is new and it's not really all that different. It's just a little bit different from everything we've seen for decades and decades and decades. It's just a little bit of a new version of things that we've seen before. So while you're listening to Mike, please keep in mind that this is a new drug. These are new drugs that he's talking about, but they're not so different from things that you already know about that it should be overwhelming. And Mike, that's what you need to do. Take it away.
Thank you, Karen. All right, I'm going to go ahead and share my PowerPoint. I'll get this ball rolling. Oh, there we go. All right. So today the topic of discussion is 2C drugs and novel compounds in Northern New England. So to provide a quick roadmap today, we're going to talk about this new blend of synthetic phenylethylenes known for recreational use and their potent psychoactive effects, primarily acting on serotonin receptors. So I hope to help you guys understand, to identify and describe the core components of 2C drugs, recognize some of the key signs and symptoms of intoxications, outline treatment management strategies and potential complications, along with discussing the emergence of novel illicit substances in the Northern New England regions, which I think is one of the main reasons everyone's here today. Let's begin with foundational chemistry, and this is going to be kind of a little less than a third of the initial slide, so bear with me for anyone that's not a huge fan of chemistry. So 2C compounds are synthetic phenylethylenes. They're kind of, again, known for their recreational and potent psychoactive effects. Phenylethylenes in themselves are just a fundamental class or organic compounds, and their basic structure just consists of a benzene ring with a amine group that's connected via a two-carbon ethyl chain. So this is kind of the backbone or the starting point for really a vast array of biologically active substances. And the one that's probably most well known for its psychoactive property that we find in the wild is the picture that we see on the right-hand side, the peyote cactus or the Lophophora williamsi. So the phenylethyline essentially that we find, whether it's in your body in nature or as synthetic, kind of it'll play a role in terms of how your brain processes emotions, motivations, and energy. So endogenous relatives or catecholamines are pretty much phenylethylamines that we create in our own body naturally. So catecholamines are structurally defined by the catechol group, which we see here, which is a two hydroxyl groups on the 3 and 4 position of the benzene ring, and then the amine group to the right-hand corner. This family is typically crucial because they're crucial neurotransmitters and hormones, which includes like dopamine, norepinephrine, epinephrine, which are essential for our sympathetic nervous system, along with like various other neurological functions. Structurally, these phenethylamines are pretty much identical in the core structure that we talked about, which is really the dopamine structure, with hydroxyl groups and other ethyl chains that's added on to the end. And this is kind of where 2C compounds come in, because as we saw in the previous slide, these subtle chemical modifications can kind of change the compound's effect. So adding various chemical groups to the benzene ring of the phenylethylamine structure, known as ring substitution, can actually significantly alter the pharmacologic properties of the compound. And it was first in 1974 when an American chemist synthesized 2CB, the first 2C compound in this large family. Is marketed actually as a legal MDMA replacement in the 1980s. And the 2C designation actually comes from the two carbon chains that connects the amine group, so the NH2, to the benzene ring. And I included this depiction of, I believe that actually this is norepinephrine on top, just to give you guys a comparison of how structurally similar this 2C compound is. But
Emma, can I interrupt you just for a second here?
yeah, of course.
So, just to kind of bring the audience along, why are we going to this effort to tell you briefly about the chemical structures before we get into the clinical effects and what you do about this? For a long time, all of history of man, we've been using plants, animals, and other things with chemicals to alter the way we feel and think. And it's a party, right? It's MDMA, it's ecstasy, it's cocaine, it's whatever it is. And in the substance using world, it's been a race over time to keep changing the structures of all these chemicals that a lot of times originate in plants and animals and are very similar to chemicals that we have in our own bodies. And the idea is to take those chemicals and make little chemical adjustments to them so that maybe there's a better or longer hallucination. Maybe it's more stimulating. Maybe it makes you feel magical. And where does the poison center come in, and where do you come in as healthcare or mental health providers, behavioral health? People get into trouble while they're doing this. And we find out there's a new drug when a bunch of people at a club or a party get sick. What's this new drug? How is it different? Does it do something that makes it harder for you to recognize or manage them when they're sick? And so we're back to it's a race to change these chemical structures so that you can advertise you've got a better drug, sell more of it, cause a different effect, dodge the law if it's different enough that it doesn't meet the criteria to be truly illegal. So Mike is going into all this detail to tell you what exactly is a 2B drug or a 2CB drug rather. And that's why we're there is people are making these alterations to get something different, something better, something potentially more dangerous. And here we are. So Mike, go ahead and carry on.
Perfect. Yeah, thank you. That was actually excellent, Karen. Summary for that. So the and essentially the what we're going to focus on, especially with the next slide, is with these 2C compounds, is that a lot of the substitution is done on this fourth position, exactly as Karen said, either to get new effects, to kind of evade the law, or standard testing. Try to sell again a better, potentially better, more potent product. And these are the list of what we see as common 2C compounds. And I'll just kind of briefly show you guys if you look over to the chemical name, the fourth position, which is the fourth bromo, for etho, for iodo, for chloro, for methyl, for propyl. These are the substitutions or changes that they're just making to the essential core structure of the 2C compound. And by adding on a lipophilic substituent, they are able to change how quick a drug is acting, how long it can stay in their system, whether it's duration of effect, how quickly it can be eliminated. So these are all things that people who are making the drugs themselves are making these 2C compounds are and trying to either get ahead of the competitors or again branding for like a novel branding as a novel substance. So there are certain ones like 2CE, which has and a lot of these information that we have is mostly anecdotal, but it's reported to have more potent and intense effects versus like 2CB and 2CI. Users kind of compare to LSD. 2CB again is the one that we've have a little bit more familiarity just because it was actually on the market legally, and it's compared to with higher doses as like a combination of MDMA and LSD, but a lighter psychedelic version than psilocybin. And then 2CT7, a lot of people state that this has like one of the longest duration of effect, anywhere up to like 15 hours. Just to again kind of give you an idea of what we're looking at when we talk about like the 2C family.
And so what Mike's trying to say is when he's saying something's lipophilic, it likes fat better than water. And if things like fat, they can get to your brain very quickly. So, and sometimes they last longer. It depends on the various drugs, but they're making these very specific alterations with the intention of seeing if they can change that high and make it different. And it's unlike a drug that's studied by the government pretty well before it's released. These guys are just in a lab, they're making these alterations, and as healthcare providers, all of our information is based on assumptions we make looking at these chemicals. And then what do these patients look like when they show up in our emergency departments with no warning of what to expect? They just show up. We see what we have, and then there are various websites that we can visit that give us an idea of what the users think the differences are. And we actually do use that when we make some of our clinical decisions because some of those effects they describe can translate to medical problems that we'll have to manage. So, all of these things that they're doing are, again, for very specific reasons and will affect what you see clinically.
Exactly. So the main mechanism of action with these 2C compounds likely revolves around the serotonin receptors in the brain. So they can act as either agonists or partial agonists to kind of activate the receptors, and particularly focusing on the 5-HT2A, which is the serotonin 2A receptor. That is going to be likely the main driver to mediate their likely psychedelic effects, which is what the user is looking for. But unlike many other phenylethylamines, 2C compounds generally do not act on like the monoamine releasing agents or like the serotonin reuptake inhibitors, though again, because of all these different formulations or different compounds in there, there probably likely will be exceptions to the rule moving forward. So, at this time there, and I'm going to show you with some other case studies that there are some suggestions that serotonin toxicity might be a potential concern. So outside of that, there it also does have some stimulating effects, kind of like when we talk about stimulants, it's more like the phenethylamine stimulants as well. Its effect on dopamine and norepinephrine neurotransmitter is something that we can see. And just to give you an example, this is kind of along the lines of like amphetamine, methamphetamine, bupropion. And along with the other psychedelic and hallucinogenic properties of the 2C compounds or hallucinogens that the patient or the user is trying to elicit.
So, Mike, would you say that these compounds, when they take them, it's kind of like taking a hallucinogen and an amphetamine all at the same time?
Correct. Yeah. So it's a two-in-one. And that's actually kind of where we're gonna see the biggest concern, at least from like a toxicity standpoint, that we'll go over in a little bit. So this slide is just to show again what we know for pharmacokinetics parameters, and this is kind of based on standardized low dosing that we've seen in the past. In toxicology, it's really interesting because we have like a lot of the prescription drugs and certain substances that's been potentially tested by the military. We have a good profile, pharmacokinetic profile. So this is exactly what your body does to metabolize the drug. We know how quickly it works when we see the highest levels in your system to elicit the highest effects and then how long they last. In toxicology, that kind of goes out the window when these people are taking um, potentially overdoses or usually with these users that are trying to elicit a high, what they call as heroic doses. So very, very large doses to get a more profound psychedelic effect. This kind of does go out the window, but this at least gives us a framework of looking at, and especially with the primary metabolism of where they're potentially going to go, how they're going to be broken down, and potentially how they're going to interact. If there's going to be other like drug effects, especially if patients are on other prescribed medications, when they might get sick and how long they might get sick. So it might not be an exact guideline of what to expect, but maybe just like it'll frame the ingestion a lot of the times when if we see a patient that comes in that took a heroic dose early, got nervous for whatever reason, and came in before they had symptoms, we can at least use this information to determine a time frame of observation before we can safely say, oh, this patient is going to be fine, they're not going to have any symptoms.
So, Mike, what you're saying here is if somebody took something close to a therapeutic dose of one of these substances that are used to get high,
Yeah,
they, for instance, 2CB, if they swallow it, they're going to start to have an effect within 20 minutes to an hour and a half, and it's going to peak within a couple hours and last anywhere from 2 to 8 hours. But if they take a gigantic or heroic dose, everything could be a little bit different and potentially longer.
exactly. So, and that makes our job complicated, but also fun. So, and then now we're going to kind of transition over to talk about toxicity, overdose, and clinical management. The first slide I actually wanted to touch upon, which is prevalence and trend, is just kind of we've kind of talked about 2C drugs a little bit now, but 2C drugs are in general increasing in popularity, but they're still seen more in like these large city nightlife settings. So a lot of the users are younger, so 18 to 29. They started in Latin America back in the mid 2010s, and they've made their way to Europe and then is now coming into the US market. Based on everything that I've seen in terms of research and looking up, pulling out data, it still seems like Los Angeles, New York, Chicago, Miami are the main cities that are seeing the rise of 2C drugs. And again, a lot of these people aren't using them to try to harm themselves, but really to elicit that high. So they're always mixing it with alcohol, MDMA, cocaine, and along with other psychedelic and stimulants. And part of that could actually be from adulteration because it still is a street drug. And adulteration is definitely a major concern, which I'll show later on. So the spectrum of effects to expect from 2C drugs is kind of what we talked about. So the physiological effects of 2C drugs are kind of the stimulant sympathomimetic effects. We can commonly see increased heart rate, elevated blood pressure, hyperthermia is something that is of a major concern to us because usually when we see cases with poor outcomes, it's usually linked with a very prolonged hyperthermia that's unable to be managed. Other reports include seizures, potentially with specific 2C compounds, which I have a little case report later on. And then from the serotonin perspective, psychologically, hallucinations are definitely a defining characteristic. And what's interesting is it pretty much causes hallucination of all your senses. So what you see, what you hear, what you taste, and even what you smell. So it causes a very kind of profound alteration of all your senses. Mood alterations are common, anywhere from euphoria and empathy to being extremely anxious, paranoid, panicky. Cognitive and perceptual changes are things like alteration in time perception, confusion, and disorientation. And then psychosis and delirium can also become an issue if also not well addressed, as patients are can become actually quite agitated and aggressive and even violent. Um,
So, Mike, that sounds a lot like ecstasy, what you just described, MDMA.
right. Yes. So it's, and again, MDMA is one of those hallucinogenic phenethylamines. So again, I think structurally they're going to be very similar in terms of what we what we see for a class of effects. And it kind of goes back to what you were saying earlier that these are things that we've seen in the past with very minor tweaks in order to try to elicit potentially a different high. But in terms of overdose scenarios, what we see is still very common to what we know. And to kind of talk about a little bit further, really, is just that variability in composition. It really does make it challenging to identify the exact substance because, like you said, it does sound like MDMA. It sounds actually a little bit serotonergic as well. So these patients usually, when they actually end up in a hospital and they're having a bad trip, they usually have kind of a complex and potentially unpredictable clinical presentation. So our kind of mantra at the Poison Center is treat the patient, not the ingestion. So there really is, we have to kind of look at the patient. It's always nice to get a history if possible. But even if we were to have the pills on hand, there really isn't any way to quickly and accurately determine what it is that they ingested. Um, at this point, there's no routine toxicology screen that would detect 2C compounds. And even doing like a deep dive into our own Nordex laboratory at Maine Health. And we also, I think, contract out with Mayo and Ward. Correct me if I'm wrong, Karen, because she's the guru when it comes to lab stuff. I did not find any gas chromatography or LC mass spec, which are like advanced techniques that are much better suited for identification of these specific compounds, but there didn't seem like there was any quantitative testing there that be able to identify these compounds, at least at this time. And even
So,
again, yeah,
so Mike brings up another reason for doing this. If you have drug testing that's mandatory for your job, maybe you drive a truck and the DOT tests you, or maybe you're a healthcare provider looking for a new job and they're looking to see if you smoke pot. Some of these new drugs that they're developing, depending on the type of screen and confirmation and testing that's done, a lot of these will not show up in the typical testing. If you present to the emergency department, if your doctor's office or primary care provider's office tests you for just general drugs, substances that might be used for various reasons that you might test somebody, this is not something that typically would show up in the standard testing. Sometimes it might cross with amphetamines, but usually not. So, if you would want to find something like this, it would require specifically looking, and you'd have to know what you're looking for. So it's a constant battle for the highest level of laboratories nationally and internationally to keep up with all these changes and make sure that on lab testing they can actually find them. So if you had somebody, you thought they used this, you really wanted to know for sure, that's a call to us. We call our buddies at the labs and we try and determine it's probably not going to show up in general testing. Is there a specific test at NMS or one of those other labs where we can find it? And if not, do we know somebody at a university who could do testing for us that's not standard? So it all adds up to being very challenging to identify these drugs and who's using them, and you have to kind of make a special effort. And if you're doing a general screening of your patients to determine, is my patient abusing or using any substances to get high? You could easily miss these kinds of drugs because they're not in the standard testing. I hope that makes
so
sense.
perfect. Thank you, Karen. So, as promised, this was one of the case reports I was hoping to just kind of highlight. This is a 2CI drug. And in this particular patient, the reason I thought that I found this one interesting was a 19-year-old has snorted a number of it, not well described amount, but what was remarkable about this particular insufflation was that he had symptoms for about 96 hours, so which again highlights just that duration effect with these heroic doses is much longer than what we have in terms of data. So he had recurrent seizures, he was myoclonic, he was hypertensive, tachycardic, and feverish. I think he actually ended up making the full recovery, but it was, 96 hours with all those symptoms is definitely a harrowing experience. So in order to try to find out more about just the prevalence and look at what 2CB, particularly 2CB products that are out on the market, I actually ended up turning to drugsdata.org, looking at the search from 2009 to 2024. So for anyone who's never used drugsdata.org before, this is an independent initiative, so it's not a government entity. They were actually launched back in July 2001 by a company known as Arrowwood Center, and it was actually known originally as ecstasy data. So, which kind of reflects its early focus on MDMA samples. Their whole purpose is to collect, manage, review, and publicly disseminate results of lab drug analyses. So essentially, anyone can submit samples to drugsdata.org. They're currently on an administrative pause by order of DEA as of April 10, 2024. But prior to that, again, anyone would send in a sample. I think the charge was $40. It's completely anonymous. They would take the sample and actually do a lot of the complicated lab work that Karen was kind of talking about to figure out, is your sample truly what it is? And it provided great data because government agencies also analyze psychoactive drugs, but they kind of often restrict access to the data that's collected and kind of limit its use primarily to law enforcement interests. They would, where drugs data kind of shine was that they would take the samples, run these LC, GC mass specs, and in I think a university lab in California, then publish the results online. Again, it wasn't linked to anyone specific, but they would also put maybe a region of the country or the country that they got the sample from, or at least a city and state if it was in somewhere like the continental United States, which is a large landmass. And this would help to show the whole idea there was to help support harm reduction efforts, to let not just medical personnel, but your common user know, there was potentially bad batches of medication that were going around in the community. So based on what I found I think there was a total of 600 and some samples that were sent in that came up under the 2CB moniker. Of the 422 substance samples that were labeled as 2CB, only 231 substance samples were actually just 2CB by itself, with no other adulterants, no other additives, which is about half, slightly half of the samples that were coming in. So, which again highlights just how prominent adulteration is in the black market. And the other samples that came up under search were essentially samples that were listed as a completely different different product altogether, and then actually contain either all 2CB or at least a subset of 2CB. And this is just a graphic of all the novel substances found in their 2CB samples in the pie chart. So based on that information, looks this large area, about 45% of it are 2CB products. The black portion is a ketamine precursor, which is used to make ketamine. the caffeine or the pink area is caffeine, brown is ketamine, and this blue section is MDMA. So interestingly enough, I know a lot of people that had requested this talk had read about the new drug TUSI, TUSI instead of 2C. And a lot of the or otherwise known as pink cocaine, and pink cocaine does contain actually MDMA, ketamine precursor A, ketamine, and caffeine. So it does seem like there's been this overlap of again people trying to maybe cheapen their overall expenses when it comes to making new substances and then mislabeling, likely intentionally, to put out on the market, which really this slide just kind of highlights how difficult it is to know exactly what you're getting when you're buying off the black market, especially if you're a common everyday user.
And just to reiterate what Mike is saying, and this is very common for substances that are popular. When ecstasy first came out and became popular again in the 1990s and sooner in other parts of the country, the samples that you got in the lab were pure. It was all MDMA like it should be. And over time, it was MDMA plus methamphetamine, then just methamphetamine, then MDEA, no MDMA. And so 2C is kind of similar. It's all popular. It's pink cocaine. It's supposed to be 2CB that has certain effects that maybe you can somewhat predict. And over time, people are selling stuff, making it look pink and has who knows what in it. So even if somebody comes and presents to you in your office in the emergency department and they say, I took some 2CB that I bought, chances are that's not even what they got. It might not even be in there. And it could be that or any combination of these other things. So that's important because, you want to know what 2CB is, but I think what Mike is telling you is, yes, I'll tell you what it is, but that's probably not what you're seeing, even if the person told you that's what they bought.
Yeah, exactly. And again, that at least from like a medical management perspective, we are it still goes back to we treat the patient or and not the ingestion. So there really is no specific antidote. One because there is kind of a lack of data sets or data points in terms of what to expect, especially with these heroic doses for the most part. But supportive care is going to be our primary management. Immediate intervention is crucial, though, in any patient that's presenting with hyperactive delirium with severe agitation, if they're having seizures, or especially if they're hyperthermic. Again, hyperthermia is one of the key symptoms where we see poor outcomes with. So aggressive cooling should be utilized to address it, whether it's chemical sedation or surface cooling. Um, and a lot of times, if you have a patient that is presenting with any of these symptoms and you contact us, we will definitely direct you away from anti-epileptics. Seizures that are caused from drug effect or overdoses are a completely different mechanism of action. And what we need to do is use essentially heroic doses of benzos to kind of counteract its activity, because benzodiazepines work by enhancing the effect of GABA. I believe particularly GABA A, which is like inhibitory neurotransmitter, and that overall will help reduce central nervous system excitation. It also helps by decreasing agitation and muscle tone. So in those patients that are like quite agitated and psychotic, all that extra energy, muscle movements is going to lead to actually worsen any hyperthermia they may have or may develop, and it also prevents, formation of like rhabdomyolysis, which is not great for the kidneys. So when we give recommendations when it comes to benzodiazepine doses, a lot of times either the provider or staff on the other end are usually uncomfortable because we utilize a lot more than what they consider to be institutional norms. Because again, we're not necessarily fighting just the, well, I mean, we are fighting what we're seeing for the patient, but we're also trying to fight off a potentially massive amount of drug that's going to be floating in their system, the patient's system.
And let me kind of just add to this or put a fine point on it. As an example, I'm going to give you a case example and then kind of walk you through why some of this stuff is important. We have a bunch of teenagers out at a concert outside. It's summertime, super hot, and they're using these kind of drugs. And in a whole group of teenagers, almost all of the teenagers are just getting high, but one of them, instead of getting high like everybody else, is just kind of out of it and confused. They're teenagers using drugs at a concert, and nobody wants to get into trouble, so they don't ask for help. And then when everybody starts to recover from their high and have enough sense to say, gee, I'm worried about this other teenager that still doesn't look right, then they ask for help when she starts having multiple seizures. And this is all from a 2C like drug. Not 2C, but very close to it, and similar problems. So by the time EMS gets to this person in this outdoor concert, they've been seizing repeatedly. They take them to the hospital. Their body temperature when they arrive, their heart rate is fast, their blood pressure is super high, and their temperature is 107 degrees Fahrenheit, which is way too high. And it takes them extraordinary efforts, large amount of benzodiazepines, external cooling. Michael, talk about how you would do this. But by the time they got this young person's temperature down, she was able to survive her overdose in terms of her body was mostly alive. Her kidneys failed, her liver had severe dysfunction, and all of those things recovered over days, but she had brain death from that really high body temperature. And so I think knowing these drugs are out there, knowing that the effects can be severe, and knowing the tendencies of young people not to want to get in trouble and not seek help. And then even for the providers, it's not that common to see someone coming in with 104, 5, 6, 7 temperature and to understand we have to stop them from moving, whether it's sedating them heavily with the benzodiazepines, Valium, Ativan, midazolam, Versed like drugs, very high doses, like Mike said, and very aggressively cooling them, which he'll talk about. If you don't do that, even if you're able to save your patient, you might not be able to save them from brain death. So these drugs are mostly getting people high, but there can be some very bad outcomes from using these drugs.
Yeah,
Go ahead, Mike.
thank you. No, and the other thing too, actually, I should mention is like if we are not, we want to be when we see a patient that comes in with like 104, 105, 106 degrees Celsius temperature and we suspect like an overdose scenario, we're probably talking matters of hours that we have, if maybe even less than that, in terms of trying to cool them as quick as possible. So if we're giving typically our recommendation for like a Versed is like 5, 10 milligrams every 3 to 5 minutes. If a couple of those are not helping, we should consider intubating and adding on propofol. And realistically, if they're still hyperthermic after that point, even using like a paralyzing agent like rocuronium is not out of the picture. But obviously, if hopefully you guys will never have to deal with a patient like that, but if they do come in, definitely something I would say to give us a call at the Poison Center, and we can always loop a toxicologist in. But in terms of otherwise optimal cooling, which is this is more kind of, I will say, mechanical. The ideal is again to bring them down below that 104 degrees Fahrenheit and try to get them to that preferred normal range of 36 to 38. There is a couple of methods here. The first one is evaporative cooling, which is just removing the clothing, spraying the skin with tepid water and using fans to cool them. Actually, in the winter time, especially Maine winters, if they're in the critical care access bay, you could always open the door and bring the patient closer to the outside, and that will actually do a good job. Obviously, be wary of things as frostbite. So conduction cooling, these is just applying ice packs to major areas, or major blood vessel areas, so neck, armpit, and groin. One of the caveats here, I will say that I've seen is uh, sometimes when we give this recommendation, certain hospitals will want to try to get like a cooling blanket because it's like a larger surface area, and sometimes a lot of crucial minutes are kind of lost trying to locate a cooling blanket, and they'll maybe after like 30 minutes, an hour, realize that they just don't have one. It's if you have any plastic bags and access to ice, it's better just to pack the area first before even looking for a cooling blanket, or just disregard a cooling blanket in general, because it's the ice packing to the major blood vessel area does probably just as good of a job, maybe a little bit less effective, but it kind of will suffice. And the actually what's preferred for optimal cooling is ice water immersion. This is essentially just submerging the patient's torso in ice water. Great for heat stroke. Not sure how practical this is with a lot of EDs, and even with outpatient practices. So I put it on there. It is good at um, for cooling rapidly, but again, especially with critical care access hospitals, we may not have that option. And realistically, if we're able to combine some like the conduction cooling, evaporative cooling with chemical sedation, we should hopefully get a good response of the patient. So there's one thing I did not put on the slide is like cooled IV fluids. I think there's still a lot of unclear benefits, and there's not a great consensus on whether or not there actually might be th those benefits outweigh potential harm. So that technically is another option, but I think a little bit more research needs to be done in that before it can be really optimized. And then this slide is just talking about potential long-term consequences. Obviously, as we kind of harped on, the scientific research is notably limited. So with most information that we have, especially with these larger doses and abuse of 2C compounds being anecdotal or from like case reports, so it makes it really challenging to definitively assess chronic health risks. But there are certain things or anecdotal evidence that may suggest like persistent potential issues like persistent psychosis, hallucinogen persisting perception disorder, which apparently they're finding not just with 2C compounds, but with also like large doses of other hallucinogenic substances like psilocybin. Again, these are usually with very large doses over a chronic period of time. And there was even a case report of neurological damage, of cerebral vasculopathy in a patient, which I'll kind of expound. Actually, I'll just tell you about. It was a 43-year-old female. She was at a party. It's unsure who made a batch of liquid 2CB. They apparently synthesized it based on a recipe that they found online. The other party goers had no symptoms at all, but apparently this patient, without knowing her med list, of course, 48 hours after the ingestion, developed headache and confusion, showed up to the hospital, and then subsequently developed progressive encephalopathy and quadriparesis, which did not improve over several months. They did an MRI, cerebral angiogram imaging, and they showed like profound vascular abnormalities of the large, medium, small caliber vessels, with subsequent watershed infarction. And they also did rule out like inflammatory processes. I believe they got a brain biopsy and cerebral spinal fluid from the patient. So again, that was just one case study. So it's hard to know, exactly what the overarching long-term consequences look like, but there are some potential, actually pretty significant issues that we were to think that that case report was directly related to the 2CB liquid. And this is just to kind of bring it back to Maine, right? So we learned about 2CB products. What does that look like for our neck of the woods and our population? So looking at the broader picture of 2C drug usage trends, this was a national survey on drug use and health back in 2022 and 2023, specifically for Maine. And I highlighted here just hallucinogen use in the past year. It looks like there is actually a somewhat of a higher population than maybe some people would expect. So this is per thousand population. So overall, in the number of people that were surveyed, 55 people between ages of 12 and up per thousand is suspected to have used hallucinogen, some form of hallucinogen in the past. That being said, it's really hard to I mean, so essentially we're using this data to try to infer whether or not these are 2C compound ingestions, when realistically there really isn't any good survey that looks at 2C compounds specifically. So it's hard to tease out, when they talk about hallucinogens, are they talking about 2C or potentially more commonly LSD, psilocybin? There's a number of psychoactive products on the market itself. But there does seem, at least there to be a little bit of an acceptance in the general population. There was only one per 1,000 in the 12 to 17 category. Mostly, again, it's the 18 to 25, and then they kind of just grouped into 26 plus. So usually 18 to older are the ones that are generally a little bit more accepting of hallucinogen or admits to using hallucinogen in the past year, which is higher than like cocaine or opioid misuse, but still much lower than marijuana or alcohol, which, marijuana is much more freely available as well. So in order to try to actually capture 2CB data, I had to kind of expand it to a federal level. So from a enforcement perspective, this is a DA data on encounters, which they describe encounters as essentially any substances that are captured on a national level that's collected by the NFLIS drug, which is like the National Forensic Laboratory Information System. It's a program run by the DEA. It systematically collects drug identifications, results from forensic labs across the US, and analyzes it for law enforcement cases. So as you can see, it's kind of there, from 2005 to 2015, it was kind of sparse and just showed up here and there. But from 2019, they definitely saw an uptick of 201 encounters. And from there, it's kind of more or less died down. And actually, I guess, give more of a frame of reference, even though at its peak, it was 201 encounters. In 2019, they received a total of 1,521,000 drug reports. So overall, what we're seeing on a potentially federal level is that 2C encounter or 2C prevalence is still fairly low based on everything else that is on the market. So at least for novel psychoactive substances, then what are we seeing if it's not necessarily 2C? So in terms for the phenethylamines, it's still ecstasy, Molly, so pill and powder forms of MDMA are still kind of at the forefront. But in general, the forensic lab have actually seen decreases of submissions by 20% each year, starting from 2022 and 2023. Bath salts um, are kind of the other novel psychoactive substances, though have definitely been on the downtrend since like 2019, but it's ever since it's made its peak around like 2016, 2017, when it was all over the news. I'm sure you guys all have heard about it, especially in Maine. I know it was a lot of talk in our neck of woods here, but it's essentially the stimulant effects. Similar to methamphetamine, cocaine, and MDMA just ramped up, and it was such a problem because it was everywhere. So online, you could get it online, you get it at smoke shops, gas stations, convenience stores. But ever since they have actually been cracking down on it, it's seemed to actually have helped. And there's been overall downtrend of samples that we're seeing on a national level. And this was actually a New York article title that came out on April 16, 2025, which is perfect because when I was making these slides, this actually just popped up on my feed. And it says, as fentanyl death slows, meth comes from Maine. And this was a direct quote from Rick Desjardins, who's the director of the Maine DEA. So he just states that fentanyl is still a big deal, although from what we're seeing in the market, there's lessening of demand and cartels are switching products to methamphetamine counterfeit pills, and crack. And to back that, to back up what he was saying, looking at the NFLIS, since 2017, methamphetamine has been the most reported drug to that system. And these next two slides just kind of shows what essentially we're seeing. So this is DEA seizures per kilogram in from 2021, 2022, and 2023. Granted, we've been kind of seeing a downtrend in cocaine. Cocaine is still per weight the most the drug that we are still seeing on the market. Methamphetamine is on there, fentanyl and heroin. But in terms of death, we're actually seeing fentanyl being the main issue, as we all have heard about in the news. Um, Fentanyl death has been slightly decreasing as of 2023, but and along with methamphetamine, but they're more or less kind of still consistent and still an issue. One thing I should mention on this graph is that the way that the CDC reports deaths, so if there is more than one drug can be reported on a death certificate, the resulting death do not form discrete the death counts don't form discrete, mutually exclusive categories. So that means if a person died and it was suspected for or reported for both fentanyl and cocaine in their system, it will be counted as deaths involving fentanyl and included in deaths including cocaine. So the overall sums of death attributed to specific drugs will likely exceed the total number of drug overdose deaths. So in order to try to, again, this now we're kind of going down the pathway of like, so what are we seeing for methamphetamines if it's something that we should be actually concerned about or potentially be seen down the pipeline in Maine? Looking at the CDC data starting from 1999, we are seeing that death with methamphetamine is starting to slowly rise up. And I like this graph because it separates deaths with methamphetamine and deaths with any other synthetic opioids. Again, the primary one being fentanyl. And you do see that there is like a clear difference when fentanyl is included in the product that the user succumbs to. And this is just additional information by adding cocaine to see if there's really was any difference, and more or less the trend line remains the same. But bring this all back, this national picture back to Maine. So right now, there really a lot of what we have available to us in terms of looking at prevalence of 2C compounds, there is a lack of specifics. A lot of what we're able to find really is looking at hallucinogens and trying to tease out whether or not it's an issue. But in general, what I would say Maine's um, Maine's trend kind of does match what we see on a national level, and Maine's overdose mortality does trend large, or Maine's mortality trends based on this slide largely mirrors what we see from the national crisis, which is still opioids. Methamphetamine deaths from 2021 to 2024 still kind of about hasn't really changed all that much. But again, sometimes it takes a little bit of time for the market to show. And again, if people are using it, well, shouldn't say using it appropriately, but using it at less heroic doses, we typically don't see as many deaths as fentanyl, as we saw in the previous two slides. So, but the key takeaways here is that 2C compounds are still a class of concerns. The available data indicates that they're not a primary driver of at least overdose deaths in Maine, unlike the overwhelming impact of fentanyl, other opioids, and methamphetamine, obviously. So this kind of directs our public health and clinical efforts towards the most pressing threat. And again, what we're going to see in the communities. So this slide just looks at MDA 2021 reports, which shows that actually, while fentanyl is still the primary drug threat, we are actually seeing more cocaine and methamphetamine in our main markets. So cocaine seizures have increased 413%. The base, which to make cocaine, it has increased 66%. And then methamphetamine seizures have increased 215%, all from 2019, whereas heroin seizures have actually decreased by 78%. So there is some there's definitely truth to what Rick was saying, in that we are maybe seeing more of a trend away from downers into stimulants, um, which 2C compounds or not, I'm sorry, so it's a 2C compound that don't necessarily belong in, but still are kind of concerned. So in conclusion, 2C compounds, diverse class of synthetic psychoactive substances. They have very complex pharmacology and a potential for significant toxicity, which includes severe physiological, psychological effects, um, the risk of excited delirium, the risk of hyperthermia and fatality, but the national data in general, and likely our own state data, shows that the presence in the illicit drug market, particularly 2CB, specific uses in seizure data for 2C compound, it's very limited. But based on what we're seeing on like a national level, the the still overwhelming driver and what the main concern that we at least from a illicit market, it looks like it's still fentanyl, other opioids, and um, with this rise of methamphetamine, potentially methamphetamine moving in the future. But it's so important to understand 2C compounds, and recognizing signs and symptoms, continued vigilance, research in NPS, and targeted public health strategies are kind of essential to address whatever evolving drug crisis is going to be, at our forefront moving into the future. So with that, that's my references. And then thank you so much for everyone's time, and I'll be happy to take any questions if there's any.
Thank you so much, Michael and Karen. I want to direct everyone first to the chat or the link for the evaluation, as well as the link if you have any specific coaching or training requests. We have the link for the technical assistance request line. But I do have one question I think we have time for. Are they seeing more instances of xylazine and, I might not pronounce this right, medetomidine use?
So I can answer at least with the xylazine. I think we might be seeing like a slight increase with xylazine, at least from poison center calls, but it's still very few and far in between. Um, I think one of the things I always ask for when there's a suspicion for xylazine is these like weird necrotic marks, so that are far and away from the site of injection, because usually they will use like an IV formulation or like a parenteral formulation. Um, but I don't know that we've really seen a whole lot in Maine. Actually, I feel like it's a little bit more prevalent in Vermont. I don't know.
Yeah, and I would say that I think it's out there. I don't think we've seen a large enough amount that it captures our attention, at least from the poison center perspective. And to be honest with you, it's big in the press, xylazine and medetomidine and all of that. But from a toxicologic perspective, as long as they don't have some of the skin issues that Mike was describing, it's easier to deal with those things than the actual fentanyl. So
Yeah,
we'd be so busy dealing with the fentanyl that that wouldn't even hit our radar for anything we needed to worry about. So I think that it might be better to follow DEA data on that. But um, that's my not political way of saying I don't care that much because that's not our biggest problem. So it hasn't captured our attention at this point. I'll say that. Not enough to be a serious concern for us.
yeah.
Thank you. If there are any other questions, since we are 1 minute over, you can forward them on to me and I can forward them on to Karen and Michael, and they've shared they're happy to answer them. But thank you so much, Karen and Michael, for this great presentation, and thank you